Okay, this is Dr. Khan recording today, December 23rd, re-record December 23rd for the asthma overall overview that we did a couple of days ago. Before we start on talking about anything else, I'm just going to give an overview on asthma and discuss its definition in light of COPD, then look at its pathophysiology, look at its overall overview for its treatment and biologics. So that's what we're going to be looking at today. So let's just dip right into it. So the overall, when we're looking at asthma, we know that asthma is a part of the spectrum of COPD. COPD being a heterogeneous group of disorders, and asthma being part of it. So if we're comparing asthma with COPD, both are chronic inflammatory obstructive airway diseases. And so what would be the difference between asthma? Asthma from the onset we know has bronchial hyperactive or reactive airway disease. So it has got that hyperactive airway reactivity versus COPD, which may not have that. So the second point that I want to emphasize on, that asthma has a variable course. That means that it on days is going to be better, on other days it's going to reverse back completely to its original state. That's sort of like classically, we're talking about the classic definition here. So it's going to have that variability. And COPD, on the other hand, it's progressive. It is also reversible. Sorry, it's preventable, but not completely reversible. So there's a bit of difference in here between the two, right? Progressive, it's got its progressive nature, which is also to some extent reversible, but not completely. And then we define it as it being preventable. We can prevent the progression of its course. So let's review this further in the light of what we have just discussed. Okay. We're going to look at the next part. We're going to look at its pathophysiology of asthma when we're particularly talking about it. Now we know whenever there is an early reaction, there is bronchoconstriction, meaning the airway becomes sufficiently tight, which is going to happen. There is going to be some component of airway restriction and bronchoconstriction, with COPD as well. Whereas the difference is going to be, COPD classically has been defined where there is some mucus plugging in the airway, and importantly studied in light of the eosinophils that have been there. Eosinophils. So we want to remember asthma being having mucus plugging early on, and this mucus plugging initially being a sort of an eosinophilic predominant. Vascular permeability, and remember this, that whenever there is inflammation, the vascular flow has to somehow, or one way or the other, increase, right? So the blood flow classically. Hence, we prefer to keep asthma patients a little bit on the drier side than versus and any of the other conditions. So asthma, you want to think of that as well. The bronchial wall edema is going to bring in cellular infiltrates. Cellular infiltrates in this case are eosinophilic and eventually going to result in more changes. Now, remember, the other, yes, there's going to be some sensitivity reaction. There's going to be release of mast cells. Mast cells releasing, mast cell then releasing more contents, which going to affect a number of areas afterwards, which going to interleukins being one, cellular infiltrate with other stuff that are going to be affected, and release is so there's a lot of the cellular infiltrate that is going to be affected by this. So let's go back and discuss one of the other parts I want to discuss is where are the changes going to be? Now, these all changes we described is all at cellular level and changes that are happening. Now, what happens after that? Well, there is a component of where we're going to discuss or want to remember remodeling. And the classic sort of remodeling that you want to think of is in the lamina propria of the basement membrane, right? So here, if it starts to become, even in asthma, if it starts to remodel, there is going to be, well, there is fibrosis, and then hence the definition of where it's completely reversible may not be reversible, right? So you want to remember that there are some changes in the lamina propria of the basement membrane of the cells that there are there, right? And then the last part we want to remember that there is a smooth muscle layer in the airway that is going to get remodeled later on, maybe hypertrophied, or some fibrosis permanently, and hence are going to affect what the elastic recoil forces, the elastic recoil forces in the airway. So if this is eosinophil, now do remember there's some literature out there that during an attack, there may be, yes, it's mucus plugging and eosinophils, but there may be, guess what, neutrophils in the airway that can affect, and then you want to just remember a little bit of this overall context of what is the pathophysiology that we are discussing and what is involved and not involved, okay? So let's just look at the next part that I want to just discuss, dip right into, is the management of the COPD, right? So this is a part. Okay, so let's just look at what are the approaches that we want to look at in terms of the treatment and further. So when we are discussing the symptoms of asthma, the second point that I want to remember is that there is a specific pathophysiologically with asthma, there is an atopy part that needs to be remembered, that there is an associated family. Let me just adjust the app. That there is an associated family history that there is an associated part of family history with asthma, which is different from COPD, as COPD may have an association strongly with smoking. And then smoking and occupational exposure is the second part that we want to remember. Besides the family history, that one that I want you to remember is a strong association with allergens. Whether these and of these, the perfume, grass, and others are very strongly linked with. Whether this allergens may result in a rhinitis sort of symptoms or skin SOS to speak, it could be either. So remember, asthma, the atopy, family history, allergens, COPD more, smoking, occupational exposure, and other exposures. Okay. So what else with the asthma that I want you to remember? One, the other is its variants. And what are the variants that we want to remember in this part? Well, has it got an association with, for example, exposure to workplace is one. Workplace exposure. They go to work on a Monday. By Friday, the symptoms are really bad, and then on weekends they generally get better. So occupational workplace exposures. What about exercise? Yes, there is also a variant, exercise induced. Yes, remember just that there is aspirin, polyps, is the other ones that I can think of. That there is an association with, and that we do want to keep that in mind. Okay. And then what else is there that we want to remember? Well, yes, then there are the ones that are including in the differential diagnosis that I want you to remember. What is that? That allergic rhinitis, always rule that out. Allergic rhinitis, make sure that there is no posterior nasal drip and GERD. Always factor that in. And then lastly, the ones that we're going to remember always is the three eosinophilic syndromes, the ABPA, Churg-Strauss, and eosinophilic pneumonia. So just factor these three differential diagnoses and an association when the eosinophil levels are especially high or increased. Yes, there may be an IgE level with this. So these are sort of like the classic asthma mimickers as well. I want you to remember that. Let's come talk a little bit about how do we divide asthma. So asthma basically is divided not on, as compared to COPD, which is based on the FEV1. Asthma is divided based on its symptoms. And in its symptoms, you want to remember whether these are intermittent or these are persistent symptoms. So just want you to remember that. And then if generally less than 2 times a week or less than 2 times in a month night symptoms, you want to keep those 2 numbers in mind. And also you want to factor in later on, especially when they start becoming more moderate or severe persistent, that the FEV1 starts to decline. And remember, we discussed a little bit about how remodeling starts to happen. We know the usual letter. This everyone will have a look at their own notes and can look at the specific therapy. Yes, in the beginning it's just a SABA, and then but when it becomes persistent, won't you remember you think or should add and first line of treatment in asthma is the ICS versus COPD, where the first line of treatment after the SABA that is there is the LAMA classically. Then is the leukotriene receptor antagonist without the ICS. Is that an option? And yes, it is an option. Just see the guidelines here. If it controls symptoms, yes. If it doesn't. But if you still have to use the inhalers more, you're gonna add an ICS and add or substitute that with the leukotriene receptor. And then when we come to persistent, I want you to just remember that it is persistent symptoms. They have nocturnal awakenings, which is more than twice, and we said it could be up to a weekly, and then it generally has daily symptoms where you have to add a ICS and a SABA with other a LAMA if needed or a LABA if needed. So right here, a LABA and a LAMA, which is sort of like where you go to a triple therapy thing. And then the stage 4, when it becomes more severe, persistent, you want to think of adding biologics and others. So just have a look at the treatment here and just you adjust the steroid dose as you go up. You do remember your leukotriene receptor antagonists, and then you want to maybe consider adding, besides the triple therapy that you've considered adding, oral glucocorticoids. They may be needing some medication already for that, but then at the end, just remember the biologics. And just a few word on now, we just want to have a look on the biologics that we've been discussing. I know it's a busy slide here, but just look at the epithelial receptors, and I want you to start basically from the mast cells and something that we discussed just a little while ago. And then what are the treatment options? Well, the Xolair, which is omalizumab, controls the IgE, just association with Xolair with IgE levels. Whereas Dupixent, D for Dupixent 2, you want to remember IL-4 and IL-3 which limits the release of it from the T cells. Interleukin T cells. Dupixent is 2 receptors, 4 and 13. Lastly, I want you to also remember the Nucala, one of the earliest biologics that's been acting on interleukin 5, and which is also 5 is for Faserna as well, which is 5, which is benralizumab. So Xolair, Dupixent, then Nucala, Faserna, and then the one of the newest one, the anti-TSLP, which is preventer, release preventer. You want to remember the Tezspire or tezepelumab of the group. Okay, so this is sort of like a little overview of the biologics. Yes, you can remember a few of the others, but I think these are the ones that you want to really put in your book and remember for sure. Okay, so what in a nutshell is what is the biologics side effects? Mostly they're very safe. They have a pretty safe profile, but you do want to remember that the Ig level and the eosinophil count is what is helps you base the treatment. And whether it's Xolair skin site of infections, Nucala, eosinophil levels every 4 weeks, again site infection and additional headache. Yes, there could be some other, and then Faserna, same profile, pretty safe again, 4 weeks, and then it becomes 3 doses, and then 8 with every second month. So even a longer, prolonged, you're just prolonged an injection every second month, not even every month, which is in Nucala. And then Dupixent also has a pretty safe profile based on the eosinophil, and then an injection that is given. Dupixent every 2 do 2, we said 4 and 13 is it's every 2 weeks, okay? And then residuprumab is every 4 weeks as well. So this is just like a little overview of what we've sort of like reviewed. The definition, just in summary, we discussed that the asthma versus COPD differences. You want to remember that COPD is progressive, preventable, but it doesn't have the variability that we see in asthma, which is completely, in the beginning especially, reversible. Asthma has an atopy, family history association, and you want to think of eosinophils, IgE, and others when you're treating this. COPD, on the other hand, and we'll discuss this separately, is more a smoker and an FEV1 based classification, whereas asthma is based on whether you have persistent or intermittent symptoms. And then the treatment is very different as well, where you remember that asthma, the ICS plays a very critical central role as it does, and then the newer control with biologics is very important. And that's it. We'll just go over some cases following our discussion.